Following that will be John Wilson, who will talk on hope and authentic religion. So there are at least those two very nice talks coming up very soon. I want to introduce Warren Holleman. It's been my joy to get to know him and meet him over at some of the palliative care meetings that we've had over at MD Anderson. Warren Holleman is professor of behavioral science and director of the Faculty Health and Wellbeing Program at the University of Texas MD Anderson Cancer Center. The mission of that program is to reduce stress and burnout of physicians and researchers who are engaged in treating cancer patients. He has a most illustrious past history, and I got to mention some of this because I love it. Well, first of all, he did some very wonderful things. He's been, for the last 8 years, he served, for a period of 8 years, he was the director of the Baylor Search Clinic, which provided medical and psychological services to Houston's homeless population. And another group, also, he was executive director of the Baylor Star of Hope program for counseling. And both of them providing mental health services for the homeless women and men of our region. Very important work. He's the founder and director of Compassion and the Art of Medicine lecture and performing arts series. It's now in its 23rd year. I'm most impressed. It served as a model for medical humanities education in several medical schools, nursing schools, and schools of public health. He has a seminar entitled Nurturing the Spirit of the Healer, Managing the Ethical and Emotional Demands of the Helping Professions. It's been presented in 26 cities. Got to be here in Houston soon. If it hadn't been, we'll have to do that. He has also done workshops on the power of anger, building better families, all sorts of stuff like that. He's got workbooks on that. He's published in JAMA, the Journal of the American Medical Association, and Lancet, and other medical and psychological and ethical journals. He's written a book entitled Human Rights Movement, Western Values and Theological Perspectives. I'd like to read that. I got to get it. And then he co-authored Fundamentals of Clinical Practice, a textbook on the patient, doctor, and society. And both of them have been highly regarded and written with great comments, such as this one. The British Medical Association Medical Book Competition, which he did well in, commemorated the book as in the basis of medicine category. It also reviewed a review in the Journal of the American Medical Association described his book on fundamentals of clinical practice as a book which is a gem. So again, but as if that weren't enough, he's a playwright. He's the author of 3 award-winning plays. One of us entitled It Was Never the Czar, The Comedy of Eros, and Waiting for Bordeaux. And his brother and he both wrote a 350-page book that was all about the hometown that he grew up in North Carolina, entitled Apex, North Carolina. That was the name of the town. So his book tells that story. He has an A.B., his Bachelor of Arts from History from Harvard University, a M.A. and a Ph.D. in Religious Studies here at Rice University. Pretty good commendation. He's a wonderful guy and a licensed marriage and family therapist and an American Association of Marriage and Family Therapy approved supervisor. So please give a warm welcome, if you will, to Warren Holleman, and we'll hear him speak, as he will, on professional burnout, something I need to hear about, and I'm going to be listening carefully. Come, please, Warren.
Let's see. Testing? Okay, yeah. Wonderful. Thank you, Dr. Graham. I feel that we should probably get some tips from him, a priest and a physician. And actually there's some research that shows that when people are bivocational, they're less vulnerable to burnout because they are able, they don't get stuck doing one thing. They can have a creative side and they can have a scientific side or whatever. There was one thing that you said that was wrong. I claim to be the founder of the Baylor Search Clinic, but as Dr. Cypress here probably knows, his sister-in-law founded Search, and his niece, Idolin, it was her idea. I used to supervise home visits for the family practice residents at Baylor. And Idolin one day in 1989 or 90 said, "Why don't we do home visits to the homeless?" And we had this questionnaire, a psychosocial type thing. She said we could ask them the same questions about their health and their attitudes toward health, etc. And I said, well, how would you do home visits to the homeless? She said, I'll show you. My mother has gotten interested in this area. So we started going out on the outreach van and took our supplies and their backpacks, and that's really how the clinic got started. And eventually we moved it indoors. So it was a lot of fun. It's quite an adventure. I'd like to talk about burnout today. Let's see if I can find a place to put this right here. It's something that, it's a term that's become fairly well known in the last 10 to 20 years thanks to a psychologist named Christina Masloch. I think before her time we usually talked about these issues in terms of stress or chronic stress or distress. Burnout is, stress is a great concept. Burnout, though, brings out some other aspects of how work can have a negative impact on our emotionality. So I'll talk primarily about that today. Before I get started, I wanted to just get a little bit of a feel for what would be helpful for you all. I recently gave a workshop on burnout to clergy, so I sort of did some study in that area and a lot of interviews and things. Most of my work has been with physicians and nurses, and so I even have a little bit on mental health providers as well, Grayson. So, is there any particular aspect? Actually, let me show you the outline in just a second. And then you can tell me which aspects would be most helpful for you. Let's do it that way. But before we do that, in preparing to do the workshop for the clergy, it was my brother's a minister. He's the good-looking one there, my older brother. And I was trying to find a picture. It was for his group in Pennsylvania of United Church of Christ. And I tried to find a picture of the two of us when we were young. And except when we were babies, this is literally the only picture I found, and my uncle took that. But look, this is the opposite of stress and burnout. This was my horse, Trigger, of course. He was so tall, and I was so weak, I couldn't put a saddle on him. And notice how the bridle is, I just threw it up in the air and hoped it landed. But I didn't care. It wasn't as though everything had to be perfect. As an adult, and I look at that and I say, gosh, you did it all wrong. Well, the point was to enjoy riding your horse, not to get it perfect. So did a little psychoanalysis of myself through that picture and learned some things. I think I did enjoy riding the horse. I just didn't do anything, quote, right. So the topics that I'm prepared to discuss are any of the mental or emotional challenges common to helping and health professionals. Burnout primarily, but we can talk about stress, depression, etc. But what is burnout? How is it defined? What are its causes? How is it assessed? What do we know about burnout among physicians, among clergy, among mental health specialists? And what types of interventions are most effective in preventing burnout? That's really the helpful part. If you're experiencing it today, you might want to hear that. Is there anything here that you'd particularly like me to emphasize, or would you like a little bit of each?
I'd like a little bit of each, but I sure want to know the bottom one, the last one.
Okay,
And
so don't
also,
leave this dangling.
Also, and deal with the causes a little thoroughly.
Okay. Okay, so I'll do a yes?
80% on the interventions, because I really think that's what a whole lot of us have been on the edge of burnout, and I'm just always looking for ways that I can avoid it, or that I can mediate it.
Sure, okay. So I'll cover these in a more general way, and then I'll cover this one as thoroughly as I can. How does that sound? Okay. These are the mental health challenges that I have either experienced in my life or encountered with those that I work with. Burnout is what I'll be talking about primarily. The others are chronic stress. I mean, we all have stress in our job. Stress is a good thing, really. It challenges you to do better. But if it's chronic, if it's all the time, that's what wears you down. At my current job at MD Anderson, I've been shocked at how many colleagues have problems with panic attacks. My cardiologist, one of my best friends there is a cardiologist. He says he stopped counting at 100. In a 5-year period, 100 different employees came to him. 97 turned out to be panic attacks. And one was a heart attack. And then 2 were ambiguous, I think. Panic attack is just this feeling of extreme anxiety, palpitation, shortness of breath. You're worried, you think a terrible thing is about to happen. Depression, of course, is when we have a sad or empty mood, a loss of pleasure and interest, low energy, difficulty concentrating, changes in sleep and appetite, and usually have suicidal thoughts or gestures or actions. A lot of sleep problems. Most people in the helping professions and the health professions are sleep deprived, do not sleep well. Oh, sorry. I don't know what I did. That's the other shock. As I get to know people through my work at MD Anderson, the number of colleagues who take sleep medications. That's generally not recommended by the sleep experts, but a lot of people take them. Compassion fatigue, that's sort of a secondary post-traumatic stress that we feel when we spend our time taking care of other people, and we kind of vicariously experience their suffering. And it builds up and builds up, and if you take care of 10 people in a day, you sort of experience 10, multiply the suffering times 10. That's what you take home with you. Alcohol problems, recent study of surgeons, 7% described problematic alcohol use. That's a pretty high number, 7%. That means they come to work, they drink in the morning, they're unable to work because of alcohol at times, they drink to get drunk, things like that. They can't stop drinking once they start. Marital malaise, a big impact on marriage, and there's just general workaholism. If we ask what is burnout, to define it, it has 3 characteristics according to Dr. Maslow. She wrote the definition. This is not a DSM-4 type of, quote, diagnosis, at least yet, that I know of. But it's very well studied and defined, and I think it's a very helpful concept. The primary characteristic is emotional exhaustion. A person who's burned out is almost always emotionally exhausted. They're so tired, it's the idea, I'm so tired I just don't feel anything anymore. I'm going through the motions. That's the best I can do, but I don't feel joy, I don't feel hurt, I don't feel anything. Depersonalization, that's a fancy term for I don't care about people like I used to. When my patient gets bad news, I'd feel that sadness. I just don't feel anything. I don't really care. I just want to get my job done and get home. And then some people also have a low sense of personal accomplishment. I've been at work for 10 hours. I can't think of one thing I did that really helped anybody. Realistically, you probably did a lot of things, but you don't feel it anymore. So that's the definition of burnout. Burnout is different from stress in a couple of ways. Stress is where you feel keyed up, on edge, you're like this. Burnout is when you're exhausted. All that energy has left you. And secondly, burnout has kind of a social definition. Stress is, you usually think of it as an individual thing. But when you're burned out, it doesn't just affect you, it affects your colleagues, your clients, or your patients. It affects all the people around you, your family, because you have this lack of empathy, this lack of energy, this lack of enthusiasm for life. So if you're working with someone who's burned out, it will affect the whole team. And that's the brilliance, I think, of Dr. Masloch's approach. She approached it from an organizational perspective, not just from an individual perspective. And Grayson, being a family therapist, I know, like myself, appreciates a systemic approach to things. It's not just individuals, it's the whole system is affected. And when we talk about the causes and the ways to fix it, you'll see that she defines that largely in systemic or organizational terms. Here's some more poetic descriptions of burnout. It's joyless striving. It's erosion of the soul. Dr. Glenn Gabbard at Baylor, I think that's his term. I really like that. I think back to a time when I really loved my job and I cared about everything. I was involved in things. I wanted to get on all the good committees and I wanted to be open to new ideas. I trusted the people I worked with, etc. But now I'm burned out and I just really don't have the energy to care. Instead of being connected to people, I find myself distancing myself from people. I'm just suspicious of things, suspicious of the motives of the administration. That's a person who's burned out. I'm cynical now. Here's one other way of thinking of burnout, by thinking of its opposite. A person who's burned out is emotionally exhausted, but a person who's not burned out has energy. This is what we want, is energy. The person who's burned out doesn't really care about people anymore. It's not really a moral problem, it's a psychological problem. It's like being clinically depressed, sort of. You lose some capacities. You're impaired in a way. So you're impaired in the terms of you just can't be involved with people. What you want is to have energy, have involvement, and have a sense that my work makes a difference. That's what we all want. So, what causes burnout? Dr. Masloch says that there are two myths about burnout, and I see these in my work. One is that burnout is a result of having a type A personality. It's just that somebody is trying too hard and doing too much, and they just go and go and go until they collapse. That's not really burnout, as she describes it. That may be something else. The other myth is sort of the opposite of that concept. It's that you just are lazy and you don't try hard enough. And the reason you feel burned out is that you're not motivated and you're not cut out for this type of work. A department chair where I work, actually that was his response to one of my presentations. Actually, it was to Glenn Gabbard's presentation, I believe. He says, I don't believe in burnout. I just think that some people here are lazy and they're not cut out for this. By the way, I will pass these two papers around in case you want to take a look at them. I just had the pleasure of publishing a paper about burnout among surgeons. And surgeons, in my mind, are the most motivated people in the world. And burnout rate among surgeons is alarmingly high. The latest study of 7,000 American surgeons, 40% met the criteria for burnout. That's an epidemic.
How old are they? What age were they? It's just all?
It's all surgeons. 7,000 respondents from the American College of Surgeons.
Any particular specialty?
They were all specialties. And then they did have a breakdown by specialties. A couple of the specialties were less vulnerable to burnout than others, and I can't remember which those were. Yeah, but so I just don't believe this thing about it's just the weak. But what does cause burnout? And in her research, Dr. Masloch has shown 6 causes that are organizational causes. And if you work for a big organization, I think these are really important to think of. I'm trying to get the administration of our organization to have a conversation about this because I think it's so important. Chronically difficult job demands, just having 3 or 4 jobs and having every day deadline, deadline, deadline. High demands and low resources. We can handle fairly high demands if we have the resources to get the job done. My computer has been out, not working right, for months. And I keep being told that the rules are we can't get a new one until da-da-da-da. And they keep wanting to fix it, and I'm always using a borrowed computer, and it's just so frustrating. I think we would save so much money if they'd just give me one that worked, you know, and I could get more done. Conflict. This can be conflict between people, between role demands. I was hired to do this, but they expect me now to do that and that and that and that, plus this. Or my values. I just don't feel comfortable doing that. That's conflicts with my moral values, my religious values. Conflict is normal and healthy, but if you have lots of it, that can create burnout. Lack of social support from colleagues. I'll talk about this later on, but this is this keeps coming up in more studies than almost any other cause. One study I saw of pediatric ICU docs, I believe it was, who worked ridiculously long hours, changing schedules. It's just a setup for burnout. But the thing that made a difference wasn't between those who were burned out and those who weren't, wasn't the number of hours worked, even though that's important. The number one thing was whether they felt that their work was valued by their colleagues and by others. That's very important. It's hard work, but it makes a difference, so it's worth it. Lack of job autonomy. That's sort of the sense that I'm being micromanaged. If a person has more job autonomy, if they can work from home, sometimes if your child is sick, things like that, that can make a big difference. And then poor mentoring and supervision. If you have good mentors who help you develop your career, that can make all the difference in the world. I'll come back to these 6 when I come to the solutions. So I've already really given you an idea of where the solutions are going to be. So we'll come back to this in a little while. How do we assess burnout? So this is the Masloch Burnout Inventory. It has about 22 questions, and it has 3 scales or domains to measure those 3 areas that I talked about. According to the definition that she uses now, at least, it may have been different years ago. If you are in the high risk for any one of these 3, you qualify as burned out. Looking at the studies I've seen, almost everybody who meets this one or this one also meets this one. So really, if you just look at this one, you'll get most of the people who are burned out. If you want to test yourself right now, I've developed a very short, easy way to test yourself. It's not super, it's fairly sensitive, not specific, I guess is the way they would say it. Ask yourself these 3 questions, and is your answer never, sometimes, often, or every day? I feel emotionally drained from my work. Never, every day, or somewhere in between. I feel fatigued when I get up in the morning and have to face another day on the job. I just don't want to go to work. That could also be depression, by the way. I feel like I'm at the end of my rope. If you answered often or every day for these, then you would need to take this longer test, but you would probably be in the risk category for being emotionally exhausted. I think it's I hope nobody's there right now, but I can say there have been times in my career that I've been there. And I think when we look back, we see those times and we try to do something different to prevent them from happening in the future. In terms of depersonalizing, how would you answer these questions? I feel I treat some people as if they were impersonal objects. I just get my work done, go home, but I don't have the capacity to actually care about them. I've become more callous toward people since I took this job. I don't really care what happens to some of my patients. I know that's bad, but I just don't. If you answered often or every day to those, once again, you would be in the high-risk category for domain number 2, depersonalization of burnout. And then third, your sense of personal accomplishment. Would you say I deal very effectively with the problems of my patients, my clients, my customers, whatever your work is? Or you could even say my family. I feel I'm positively influencing other people's lives through my work. My work makes a difference. I feel exhilarated after working closely with my colleagues. If you answer, here we reverse things. If you answer often or every day to these, then that means you're definitely not burned out. But if you answer, I'm sorry. Yeah, but if you answer never or sometimes, then you probably are burned out. So does that give you a feel for what burnout feels like and looks like? Okay, if not, here's a picture for you. Are there any Nick Lee fans here?
No.
No? Good. I was at Galveston, that's the seawall, eating at the really good restaurant there. I can't remember which one.
Guidos.
Probably so. And I guess Nick Lee was in the restaurant because his truck was parked right there. And I thought, World Burnout Tour. What a metaphor. I got to thinking, can you tell what that is there? Tire, you're right. It took me a while to figure it out. So he spun the tire. That's his thing. He spins tires for a living and is able to tear them in two because he spins them so fast, I guess. So, and I guess his car is inside this trailer. So, but I was thinking now, whenever he wears his tire out, he can always get another one. But we're only given one tire. This is it. So burnout is not really something that we should go for. Although I think there's an adrenaline junkie side of a lot of us that kind of thrives on getting to the edge of that, taking on a lot. So we have to be careful. All right, so what do we know about burnout among the various helping professions? I think what I'll do is give you some highlights from 2 or 3 studies. I won't give you every highlight. And that'll give you a feel for how the research works. It's pretty impressive how much research has been done on burnout among the health professions. And I have to say, especially in the surgical field. That's not a field that I would have guessed would have been really open to that sort of thing. But perhaps because the problem is so epidemic, the American College of Surgeons has fully supported doing surveys among their members, and they get fairly high response rates because the organization is behind it. So it's a fairly valid type of study. I mean, this last one, over 7,000 respondents. So that's pretty significant. They administer the Maslow Burnout Inventory, but also some other measures. What do you say? Surgical or medical? Which would you go for on that one? Do you have a preference? I'll just hit a couple of highlights from each one. Okay. So we'll skip that one. Okay. So this is my colleague Henry Cure that I wrote this paper with. He's a surgical oncologist, MD Anderson, and he did a survey of just the Society of Surgical of surgical oncologists, just the surgeons who work with cancer patients, which is a much smaller sample than what you have in that study. And in addition to administering the Maslow Burnout Inventory, he asked them questions about career satisfaction, their practice characteristics, and their quality of life, and tried to see what correlated with what. And the number he got, we'll just focus on this one. Overall, about 1 in 4 met the criteria for burnout. To me, that's alarming, that's epidemic, but that's actually lower than many other studies, up to 40%. What correlated with being burned out or not being burned out? Younger surgeons were more likely to be burned out than older ones. Women surgeons more than men. And the thought there with these two is that they're juggling children, family stuff, plus their work a little more. And plus they probably, as we get older, we usually learn to not be quite as, not try to do everything. But probably it's mostly about the family obligations.
Is the female part also the fact that the older ones tend to be predominantly male, and so there's some friction there?
You're right. Oh, I was thinking also there's just not very many older female surgeons. Right. But I think that if you were in a work culture where your organization didn't appreciate what you're trying to do in terms of your family, and the surgeon culture traditionally has not appreciated that, or many work cultures have not. So I think to be a woman surgeon would be extremely challenging. Yeah. Those who spend less than 1/4 of their time doing research had higher rates of burnout. And the thought there is that they're not able to be creative, they're not able to use the other side of their brain, they're not able to pursue research questions. When you can do some of that, it makes your work and your life more interesting. And this is kind of common sense, but those with a lower physical quality of life. In every survey you see almost, those who exercise are not as likely to burn out. This screen found 31% had significant symptoms of burnout, and based on the psychological measures, 10% would be predicted to meet the criteria for major depressive disorder. To me, that's pretty high. And that means currently, not at any time in the past, but currently. And 7% problematic alcohol use. Once again, that's pretty scary, too. These are some of the key. If they checked yes to any one of these 4, this is self-report. So it could be even higher. Some people might not report it. Okay, so that's an example from the medical world. Why don't I skip over this and give an example from the world of mental health providers? Let me just go through this. Okay. This was a study in England about 5 years ago. And they administered a general health questionnaire and then the burnout inventory, descriptions of their job and their job satisfaction. And I'm going to talk about the psychiatrists and the social workers. First of all, that general health questionnaire, it's you answer lots of little questions, and then they can predict whether you would be positive for major depression, generalized anxiety disorder, some of the most common mental illnesses. And this, how many do you think were predicted to quote, test positive for depression or major significant anxiety disorder?
10%?
Yeah, that's what I would have guessed. Among the mental health social workers, 47%. Psychiatrists, 25%. Now, this was done at a time in England when there were some changes in the way their work was being done, and there was a lot of angst about that, so the numbers are artificially high. That's what when they write up the discussion of the study, they say that. But still, they're not claiming it's still going to be really high without that. So the numbers are a little higher than they would usually be. But that was pretty surprising. And they were particularly high around the mental health social workers, on emotional exhaustion and sense of personal accomplishment. According to Dr. Maslock, if you score greater than 27 on her scale, then you are at high risk of burnout. Well, the mean score was almost 27, so almost half were there. And pretty much similarly there.
One of the things that I think that reflects from working in an inpatient psychiatric setting for over 10 years is that the psychiatrists come in, they review the treatment plan, and they say to the family therapist or the social worker or to the other mental health professional, need to do this, and this. Then they leave.
Right.
Okay, and then you're kind of caught holding the bag of documenting this, meeting with the family on that.
And you may have 5 or 10
Yeah.
cases. Yeah, right. This is really what I wanted to show you here. What this study does for us is shows how organizational factors influence burnout. And so remember I said they ask about your job characteristics and your level of job satisfaction. So they described their jobs, and they correlated. They said who's burned out, who's not, who has these job characteristics, who doesn't. And these rose to the level of significance. First of all, remember the GHQ-12 that just tested your general mental health. Those who had poor mental health described their work situation as having higher job demands than those who didn't. Remember, Dr. Maslock said if you have high demands, low resources. Anyway. They worked longer hours. They had lower decision latitude, which is the same as Dr. Maslock's concept of job autonomy. They felt micromanaged. And they didn't feel valued by their employer. Now, if we look at the 3 characteristics of burnout, you see this lack of job autonomy popping up again. You also see, now this is the issue I mentioned earlier. This was a time of a lot of fussing and fighting in England over how, I guess, the turf of the different mental health providers. But also, this is really important. These people, they didn't feel valued by their employer, so they really didn't value anybody equal to or lower than them. Being male. The female psychiatrists and mental health social workers were less vulnerable to depersonalizing than the male. And then in terms of those who had lower job satisfaction tended to have higher job demand but lower decision latitude. So that gives us a snapshot of them. And maybe just, oh yes. Do you remember Nurse Ratched from One Flew Over the Cuckoo's Nest? I actually made this up, but I thought she should say it, not me.
Yeah.
To be a successful health professional or helping professional of any type, you need 3 things. A license to show your credentials, gray hairs to show your experience, and hemorrhoids to show your concern. And actually, I can tell you, I plagiarized that from Hubert Humphrey. When I was a college student, I had this wonderful opportunity to be an intern in Washington, D.C. And he gave a speech to all the congressional interns. And that was the joke he told to all of us young people. And it was probably in about the last 2 or 3 years of his life. And he was a great speaker. But I adapted it to the health professions. He had a great sense of humor. And that's how I think he avoided burnout. He laughed at things. Clergy, burnout, and stress. Why don't I just pick one example from that. We'll do that one. Sorry. Yeah, I think this is different from the others. So how does burnout, or how does this clergy stress affect family functioning? So these scholars, and this is published in the Family Studies Journal, Grayson, studied the impact of stress on family functioning. And they interviewed it was a male survey of 136 clergy couples. They picked 6 major denominations in the U.S., Protestant. And they administered a couple of inventories. And here's what they found that I thought was interesting. The stressors that had the biggest impact on family functioning, and if you think about the life of clergy, where a lot of their work starts when everybody else gets off work. Committee meetings are at night. People can talk with you at night. The phone rings at night when people get home from work. So these were the 4 things that affected their family functioning. Family boundary intrusiveness. That's getting the phone call during dinner. That's having a lack of privacy. Your children are kind of on display to the world. You kind of live in a fishbowl. Lack of social support. In many of the smaller congregations, ministers are sort of on their own. And they can't really fully disclose their emotional needs to their congregation. That's a kind of a dicey issue. So they feel a lack of social support. And then they get moved around a lot. Children may never graduate from the school they start in. And they have a lot of time demands and expectations. So that's one thing learned from that study. I'm going to flip on forward now to what we can do to prevent this from happening. Oh, by the way, my wife and I went on a vacation in November. We were in Kansas to a family wedding. And we were thinking, we had the weeks blocked out for vacation even before the wedding. So we said, where do we go for vacation? And my wife said, let's go vacationing in Kansas. So we found this natural preserve where they preserved the prairie the way it always has been with the buffalo and all that. And it was beautiful. I took that with my cell phone camera. It's just there are only 2 buildings on the whole property. It's probably 15 square miles. And you just hike back in the prairie with a few buffaloes standing around and stuff. So what can we do to prevent burnout? Now I'm going to talk about organizational interventions and individual interventions. Dr. Maslow would not let you talk about this topic without hammering the organizational interventions. She said that a lot of organizations will hire wellness directors to, quote, fix these problems. And that's really not the solution. I mean, we do need to manage our personal wellness, but if you make the organization's culture more humane, more healthy, then you'll have you'll make a much bigger impact. So what can organizations do to prevent burnout? What's in the 6 areas I mentioned earlier? They can eliminate these 6 problems. Okay? And what would they replace that with? Well, instead of chronically difficult job demands, how about just intermittently difficult job demands? We like challenges. We need to be challenged, but we just don't need to be challenged every minute of every day. We don't need to always feel I've got 7 things I'm behind on and I'm going to get in trouble for. And then instead of high job demands and low resources, she says, give people adequate resources to do their job. In the medical field, I know productivity requirements, a corporate type of definition of measure of success has been introduced in the medical world. And a lot of physicians and nurses have resented that and said, we're here to provide quality of care, not quantity of care. But even so, many tell me, but I could meet these productivity requirements and even go beyond that if we had, access to another operating room or or another MRI machine, or a larger nursing staff, or something like that. So we don't mind working hard, but we want to work, efficiently and effectively. And then instead of chronic conflict, just normal levels of conflict. I think conflict is healthy. I mean, to me, conflict is in the middle. Avoiding conflict is bad, and too much conflict is bad. The right amount is what we should strive for. And then instead of lack of social support from colleagues, obviously solid social support from colleagues makes a huge difference. And then respect for job autonomy and good mentoring and supervision. Okay? So that's what the organization can do. Now, as individuals, what can we do? And 6 areas that I've reviewed several of the studies on burnout among the health professionals in particular, but also a little bit in the other professions. And there I found about 20 or so things that individuals can do that seem to make a difference. And then I sort of clustered them together in 6 clusters. In the area, we can change our beliefs, we can change our relationships, change the way we take breaks, change our habits, our health habits, develop new skills, try to alter our personality traits. You're saying good luck. Okay, so let's start with beliefs. And I found this very encouraging, that reading these scientific articles in medical journals, a number of them focus on beliefs as one of the keys to making a change. The studies by Tate Shanafelt, he's published more on burnout in the health professions than anybody else. And I think he has personal values. He has a strong personal value in his spiritual development. And maybe that's why it shows. But he asks questions in his studies about your beliefs and your life philosophy. And it shows that it makes a difference. These are some of the areas. Does my life philosophy stress balance in my personal and professional life? So he could have asked, how much time do you spend at work? How much time do you spend at home? That would be the standard way to measure it. But he said maybe we should step back just a little bit and say, do I really believe it's important? And that's even a more fundamental issue. If you believe it's important, then you'll probably get more out of it. Another one, do I reflect on the meaning, purpose, and value of my work? Or do I just go through the motions? Is it just a paycheck? If I reflect, even though I may work longer hours, it seems worthwhile. Do I act on my moral values? Do I nurture my spiritual life? Then the second area is relationships. And I put this in bold because this is one of the 2 areas that rises to the top in almost all the studies. Do people value and support the work I do? Anybody from my mentors to my colleagues to my spouse, my friends, my clients, my patients, etc. Do I have friends and colleagues with whom I can discuss the emotional impact of my work? When I was at the Search Center, we had the most wonderful problem that happened that taught me this. They moved, it's probably your sister-in-law, moved the lunch hour from 12 to 11:30, the lunchtime. We were under contract at that time to work until 12, half a day, and then everybody would go to their other clinic. So we said, what are we going to do from 11:30 to 12? I said, well, I guess we just do our paperwork then, because we've got to do our charts and all that. Somebody else said, no, we do that all the time anyway. I said, well, let's have a business meeting. They said, no, we do that enough. Let's just sit down and process what we've done this morning, because somebody might have had a really painful experience with one patient or client. Another person might have had a real joyous, good thing to happen. And if we can share those with each other, we can multiply the benefit and sort of help heal each other's hurts. And what we found out that we hadn't really expected is that we went to our next clinic in the afternoon with the load was lightened. You didn't sort of carry your work with you everywhere you went. So when you went home at the end of the day, you had already sort of talked it through with somebody, so you didn't have to dump it on your family and that sort of thing. So I think that's really important to have colleagues and friends that you can discuss this with.
The one thing that I always go back to is Carl Whitaker's rules for keeping the therapist alive. And one of those is, and I've tried to do it as a clinical team leader in psychiatric hospitals, is to have a cuddle group before everybody leaves, where we sit down for 30 minutes and people really vent and they say, can't believe the doctor dumped all this stuff on me, and, you know, and it allowed people to leave the hospital, without carrying all that stuff home. And as Whitaker says, dump that garbage on our spouse.
Yeah, well, that's exactly what I was saying. It's interesting, he calls it a cuddle group. Carl Whitaker, as I remember, is this big, strong guy.
Yeah.
So I wouldn't want to cuddle with him. I'm afraid he's actually famous, you may have heard, for wrestling some of his teenage boys that he was seeing who were having behavior problems. If he got mad at them in therapy, he would just fight them. This was back before, this is back in the 40s and 50s. And he thought that was a good male thing to do.
Yeah.
But he was very spontaneous. And in the medical profession, they have this thing called balance groups that are very similar. I know at Baylor, we used to have those for a while. And it's just like the cuddle groups. Okay. And then breaks. Do I take time away from work to be with my family, to have real vacations? You know, in the health professions, a lot of people say, well, I went to this meeting and that was my vacation. Well, I was at a meeting all last week, and it was a nice break, change of pace, but it wasn't emotionally, it didn't meet all my emotional needs. It was nice also to see my good friends. This was at TMFT, the family therapist friends. But we had meetings into the night, and it was not a vacation. And then breaks during the workday. Like my wife is at this community clinic where she often gets 10 minutes for lunch. And it's just, she's decided, she says, I'm an old lady now, and I'm not going to do this anymore. So she's having this Norma Ray moment, and she's going to try to find another job, I think. But she's worked with the hospital district a long time, and they just keep upping the productivity requirements, and she just, 10 minutes for lunch is not long enough. Do I exercise regularly? That's the other one of the two that rises to the top all the time. Those who exercise are less vulnerable to burnout. Meditation is quite helpful for many people. Having a hobby is quite helpful for many people. Expressing oneself artistically or creatively. Getting enough sleep is helpful for some people. I think it's helpful for all. Nutrition. In some of these studies, they ask doctors, how often do you see a doctor? And many are good at it, but there's quite a few who aren't, who are way behind on, routine checkups. Do I seek professional help for mental health and relationship problems? And then skills. And this is where assertiveness can be a really good thing. To get the career you need, sometimes you have to not just assume that things have to be the way they are. And or sometimes they are, but sometimes if we ask to do things differently, we might get a yes. And that can make a big difference. People who work with their mentors to sort of plan their careers, to map their careers. People who learn the skill of containing their career, keeping the career within certain time boundaries and spatial boundaries, not always bringing your work home with you. Then people who have good coping skills. This is basically, some people, most of us are one-trick ponies. We either have this or this, but not both. So my daughter, I'll never forget, 10 years ago, came home and said, Daddy, I'm the slowest one on the soccer team, and my coach thinks I'm slow, and he's telling me I'm da, 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 da. And I said, no problem, Annie. Here's what we're going to do. And so, of course, we're going to do wind sprints every day, and we're going to... And she said, you're a psychologist. I'm not I'm a family therapist. She said, that's not what I'm saying. I just want I want emotional support. I don't want another coach yelling at me. So I missed it. But those are the two types. I was giving problem-focused strategy. She wanted an emotion-focused strategy. Personality traits. This research is pretty clear that people who are optimistic, who have an internal locus of control, are less vulnerable to stuff like burnout. So internal locus of control means I feel that I can sort of create my destiny. I feel if something doesn't go my way, I don't just say, oh, that's fate, that's the way it has to be. I try to make things work for me. And then you know what optimism is. And those two pretty much go together. And then people who have this are usually pretty resilient and hardy. So are we born with these traits, or do we develop them? I think we can move. We kind of have a tendency to be on one side or the other, but we can move a little more the other way. That's what a good family therapist can help you accomplish.
Yes.
Okay, so since social support and exercise were the most important, I tried to find a slide that would depict those two, to sear that in your memory. So isn't this a great picture of social support? Okay, I'm going to try to climb this curb for the first time, and all my buddies are there. If I fall, they'll catch me and help me do it again. And if I do it, they'll be cheering for me. And but we're not just sitting around drinking beer together. We're exercising together. So that's kind of a nice image. So we discussed the different types of challenges. And then we focused on burnout. What it is, what causes it, how Dr. Maslow assesses it, what we can know about it from the various professions, and then what individual and organizational interventions can be made to make things better. So at this point, I think I should open it up for comments or questions. Thank you.
A personal interest question.
Yeah.
What was the ratio of burnout amongst physicians as compared to clergy?
I don't, that's a really good question. I'd have to look back. My impression is that the physicians, it's much higher. But I'd have to, shall I try to flip back and see if there were any? Let's see.
Somebody else might have a better question. I was personally interested.
Yeah. If you read the blogs, there's a lot of work-life balance blogs among clergy. And if you read that, you'll think clergy are all just totally worn out. But then when I went to my brother's group in Pennsylvania, there were 106 clergy there. And actually, I was impressed at how healthy they are. So, I don't know. I guess I don't know how fast I can get back there.
No one true answer.
Yeah, in the 1990s, the Episcopal Church of St. John the Divine was one of the first here to sponsor conferences for clergy that was called Breathing Underwater. And they didn't have to explain the seminar when they just told clergy that it was about breathing underwater.
I did not put the numbers on the slides, and I think, and I'm not sure why. I don't know. They did this Oswald inventory, which was different from the Maslow, so it would be a little bit like apples and oranges, but I could look back through and see if anybody administered the Maslow inventory. to the clergy. I didn't see that in my notes there.
Well, I would think the burnout issue amongst physicians would have increased dramatically with changes in the last, say, 30 years even in medical experiences, personal medical experiences. They're all much more, seem to be much more organization bound, whereas when John was first practicing medicine, they were, most doctors went in private practice. I mean, you practice by yourself, you have your own thing. So, and now, people they're just in big groups, and so they would fall into a lot of the things that are difficulties.
Yeah. I don't know. You physicians may want to comment on this. You've seen it closer than I have.
I do think changing the rules, so to speak, so that you have 10 minutes or 20 minutes for a patient must be very stressful.
Yeah.
And the funny thing about it, having a waiting room full of patients doesn't seem so stressful. In fact, it's joyful, because there are people out there that are looking for your services, and the worst thing would be to have the empty reception room.
Right.
But
that's true.
But then there was no back in years past, there was no limit to how long you would spend with your patient. You do what was required.
I hear that a lot.
I think the complexion of medicine has changed in terms of the pressure financially. Medicare rules have changed. A lot of docs are no longer taking Medicare patients. Many docs are no longer going to the hospital, but they're using hospitalists.
Right.
The nature of what you're practicing when you start in practice is different.
Less variety.
Yeah. And this production, you alluded to that a few times, the RVUs,
Yeah.
It's a business model instead of a
patient.
Yeah.
Right.
It's kind of, people I talk to that are experiencing burnout, and especially my wife, of course, it's more of a grind today. And they will say, 20 years ago, the question, all that my employer cared about was good quality of care, and I got great satisfaction from doing what I needed to do to help my patients. And now I've got to, it's almost like a little beeper goes off in your head every 12 minutes. And the patient comes in with 3 problems, you only can address one of them. And that's not very satisfying. And
I've had doctors tell me that.
Yeah.
Say, well, I can't talk to you but about one thing. And I'm like, well, okay, but I'm one whole person.
And my pet peeve is I think it would even be more efficient to deal with all 3 at once. Because they're usually connected. So the doctor either has to break the rules and stay longer than 12 minutes and then go home late and make the nurses stay late, or they just have to do that. And they feel like it's a grind.
Have you put anything in place at Anderson, and what you alluded to some numbers here, but you have lots of your medical and surgical oncologists with burnout, and what do they do? Do they seek help?
I really don't know. And that's my field too. My colleague, Henry Cure, is stirring up a lot of trouble, and he's got the head of the Division of Surgery on his side, Dr. Raphael Pollock, you may know him. He's been there a long time. He's a really good man, and he's concerned about this. And there are a couple other department chairs who are really concerned about it, probably because of personal experience. Well, Dr. Pollock talks about how, he's older now, but family was a priority for him, and it's always been a challenge. So we're trying to create an environment where it's okay to seek help and to make changes that are, if you need to work part-time when you have young children, things like that. But people in health professions are generally not very forthcoming, a few have come to me So I just have individual cases, but I can't tell you what I can just tell you what those surveys say. And Dr. Cura and I did circulate this article with Dr. Pollock's help among all the surgeons there. And Henry Cura says that they are talking about it, and it's creating conversation.
Your slide mentioned that the younger physicians, I believe, were more prone.
Mm-hmm.
I wonder if the fact that many of them finished their training greatly in debt
Yes.
puts a load of stress already, and then with their workload.
And their young families. Yeah, that's really, that would be quite a burden for me. One interesting thing about these two, when I read the clergy studies, the younger clergy were also more vulnerable to burnout. So, and they probably were in debt from seminary also, but they have the young families.
They are.
But there was one other suggested factor that I hadn't thought of. Basically, they said natural selection. A lot of clergy, if after, in the first 10 years, it's you know, if it's causing this to you, a lot of people drop out and find another career. So if a person is still a clergy member when they're in their 50s or 60s, that probably means they were one of those who wasn't prone toward burnout or learned early on how to deal with it. So I thought that was interesting in religious literature to hear natural selection used as a way to interpret it. But that made sense too.
It does.
My brother basically works with clergy who are burning out and that sort of thing, and having problems with their congregations, and so that's what he says too. I mean, the other thing is there are a lot of clergy who are bivocational in smaller churches and congregations, and those, in one of the studies, were less vulnerable to burnout. So kind of like you were bivocational, and that might be a good thing.
Let me ask, you write plays, or you're a playwright. Is that a great diversion for you, or is it work, and stress as well, or do you find it great being creative?
Yeah.
I guess helpful.
Yeah, I would call that. Have you ever heard the distinction between distress and eustress?
Yeah.
You know, from the Greek, eu means good. So to me, plays or creative writing is kind of energizing for me. And my goal is to retire as soon as possible so I can do that full time. My wife would say it's an obsession, though, because if I really get into it, I can't go to sleep or anything. I just keep working on it. And I love it, but then the next day you pay the price. So since taking this new job at MD Anderson a couple of years ago, I haven't done as much playwriting because that job's been pretty consuming. But I still am trying to send it out to theater, my plays out to theaters and things.
What job are you burn out?
Yeah, I don't want to burn out from that. Well, what happened was my wife and I, the first year we had kids, we were going to be this perfect couple that, had kids and two careers and all that. And we lasted a few months. And then we said, first of all, we don't have the energy. And secondly, raising kids is so much more fun than working. So instead of having this dynamic where who, quote, has to stay home with the kids, it was who gets to stay home. So we made a deal. Basically, the first 10 years she stayed home, and the second 10 years I stayed home. And each of us worked about half-time during that period. And that's when I really got into writing the plays. And I kind of miss that, because you can do that anywhere. You just take your laptop with you to the soccer practice or whatever. So that was sort of how we dealt with all that work-life balance issue.
I just wanted to mention a recent article on Medscape that was talking about the tyranny of the 15-minute visit. When you have a patient that comes in every 6 months or more often every year with 5 or 6 problems.
Right.
What primary care physicians are doing is they're saying, okay, of those 5 or 6 problems, these 3 are the most critical. You go to specialist, referral to specialist 1 for the first, to the second specialist for the second and the third. And so what they do is that's how they're dealing with this tyranny of the 9 problems in primary care, is that they're referring more people out to the specialist.
Uh-huh. Yeah. Turfing. So like if within a hospital when that happens, that was the old term for it. But yeah, and it's not as rewarding to move that way sometimes.
But they said, the primary care physician said that was the only way that they could keep it within the 15-minute visit. After they got the 3 problems referred out, they could deal with 3 or 4 of the minor problems within the 15-minute time limit.
Exactly. I see. Then they do what's called acute episodic care, which is sort of what they do with maybe the doc-in-the-box type places. But then you lose the reward of knowing the patient really well, you know, and being...
It's interesting how in all of these, what's happening, you didn't mention it, but it's true in the church as well, that it becomes a business model in which numbers matter. You know, everything you just have to get all these numbers, you have to meet all these goals, and has to be documented. And so you spend so much time within that framework instead of doing what you could actually do. And as you have said, you could do it better if you were just left alone and given a computer or whatever you needed, you could do it.
Yeah.
But I've been thinking, ever since you've been talking about this, is the teaching profession nowadays, because of all the articles in the paper about them teaching for the test.
Yeah.
All the complaints that they're teaching for this documentation
Right.
rather than, and that's what gets
For
the
the
money, so that's the business
substance of
thing
it.
again, rather than teaching,
Right.
which they know how to do, and
Yeah.
did it because they love to do it.
Yeah. I mean, that's something that older physicians say all the time is, I didn't used to spend nearly as much time in documentation.
Right.
And I got to spend my time with patients. And I mean, another trend is, we sort of touched on it, but I mean, if you ask, I don't know what your experience has been, but my wife, I would say, you know, gosh, when I was doing my training and working so hard, I said, well, I like this, but someday I'll be able to sort of, when I get into my 50s, I'll slow down. And she says she's back working, you know, almost as hard as when she was a resident, if she works full time. And so it's just, it's not that she's lazy or wants to cruise, but she didn't think that the work would get harder or stay at that level. You know, she thought that she would have a more comfortable pace. Now, maybe she should have gone into private practice or something where she could control it. Yeah.
It's not what we expected it to be.
Yeah, right. But I remember when she was in med school and she talked to older physicians then, and they'd say, oh, medicine's not fun anymore. So I used to use that argument, but now I'm beginning to think, no, it really isn't fun anymore, at least for my wife. She works 3 days a week now, and that way she can do 40 hours. Keep it at 40 hours. So, you know, if she works half a day, she leaves the clinic at 2 p.m. So it just doesn't seem like there's any